Good evening. Welcome to tonight's America's Choices in the Healthcare Debate. My name is Linda Mahan from the League of Women Voters of Larimer County, Colorado. And on behalf of the Healthcare Reform Network, thank you for joining us. This caucus is sponsored by members of the League Health Reform Network, composed of members from around the country who for the past 15 years have been dedicated to advancing the League's position on healthcare through education and advocacy. 14 League units are sponsors of this evening. The League of Arizona, of Louisiana, of Massachusetts, of Vermont, and the League of Washington, and the local leagues of Amherst, Massachusetts, Piedmont Triad, North Carolina, of Berkeley, Albany, and Emeryville, California, of Northwest Maricopa County, Arizona, of Metro Phoenix, Arizona, Larimer County, Colorado, Diablo Valley, California, Ann Arbor, Michigan, and Eastern Upper Peninsula, Michigan. Tonight, this week of our national convention, we are in a moment of awareness, which has revealed the inequality of our healthcare system. And it's also a moment which opened the window wider for the League to use our healthcare position and grassroots strength to join allies in achieving universal health care in America. Before our speakers begin, let's review our League position in brief. The League of Women Voters of the United States believes that a basic level of quality health care at an affordable cost should be available to all U.S. residents. Other U.S. healthcare policy goals should include the equitable distribution of services, efficient and economical delivery of care, advancement of medical research and technology, and a reasonable total national expenditure level for health care. Tonight, we invite you to hear the sense of urgency for reform of our healthcare system from Dr. Sierra Zachary, and to learn what key components of legislation reflect the criteria of the League's position from Hank Abrams, a League member from California. And lastly, to take home strategies for educating your members and community from Betty Keller, a Leaguer from Vermont. This caucus, including the video, audio, chat, will be recorded and shared on League websites. Please be aware, by participating in any of these, your communications will be recorded and used for educational purposes. We will be sending a link of the recording to all who registered. All mics have been muted, but we welcome comments in the chat for Zoom participants and in the chat for those watching on YouTube. You may also put questions in the YouTube Gmail account that we've set up, lwv.healthcare.questions@gmail.com. There will be a question and answer period following our first two speakers and again at the end. Now, I want to turn this over to Robin Lane from the League of Piedmont Triad, North Carolina, who will introduce our first speaker. Robin?
Thank you, Linda. It is my great pleasure to introduce you to Dr. Sierra Zachary. Dr. Zachary is a faculty member at the UNC Gilling School of Global Public Health. Her previous experiences as a health policy analyst at the North Carolina Justice Center and as a health program director for NC Child, which is a statewide advocacy organization. Sierra earned her undergraduate degree from the University of Pennsylvania, an MPH from the University of North Carolina at Chapel Hill, and a doctorate from the Johns Hopkins School of Public Health. She's worked closely with members of our North Carolina League who know her to be an outstanding ally with a talent for untangling the complex language of healthcare policy. As you are about to learn, Sierra is just the right person to address this caucus. The analysis she will share with us is based on her very deep understanding of the intersection between health and every aspect of the environment in which we live, work, and play. Her informed insights combined with her great ability to hear the stories of those most affected by the dysfunction in our current healthcare system make her eminently qualified to begin our conversation tonight, and we're very grateful that she's here. As you listen to Sierra discuss the freedom of health, which is the title of her comments, some of you will recognize a connection to some of what was expressed last weekend in the Poor People's Moral March on Washington, led by our fellow North Carolinian, Dr. William Barber, and sponsored along with other notable organizations by our very own National League of Women Voters. And so it is especially fitting that Sierra is here to help us realize the moral imperative of healthcare reform, described just last weekend as needed, quote, in the fierce urgency of now. I am proud and indeed honored to give you Dr. Sierra Zachary.
Thank you so much for having me. And I am sharing my screen now. So yeah, just to start, thank you so much to the League for inviting me to speak with you. And I also just want to thank Robin for your partnership and collaboration on the many healthcare policy campaigns that we've worked together on over the years. So moving forward. My presentation tonight is entitled Freedom to be Healthy. And to better understand my views on health policy and health reform, I guess I just really want to share my story. How did my hometown, my upbringing, educational experience, and work experience shape the work that I do today? And my feelings about how access to healthcare is a key step towards freedom. And with freedom, I mean freedom for kids to grow up and reach their full potential to thrive, freedom for Black women not to live in fear about maternal mortality, freedom for older adults not to feel that they have to spend down their assets so that they can qualify for Medicaid, and freedom for part-time workers not to worry about whether they can afford to purchase health insurance because their employer doesn't offer it. And so with this presentation, we'll just go through these, little steps of just a background of who I am. How did I get into health policy research and advocacy? How did I really come to understand healthcare reform, and why I believe that we have a great opportunity to increase single payer support. So who am I? Besides Robin's lovely introduction, I truly believe that growing up in Baltimore really shaped my understanding of disparities. So the picture on the left is the beautiful Inner Harbor, where Baltimore really lives up to its reputation as Charm City. However, not too far away, and you can see some of those high-rise buildings in the background in the picture on the right, you see low income, low rises. You may be familiar with the television show The Wire. And, these parts of the city are not that far away from one another. Growing up, I was really lucky to have a middle-class background. My parents had state and federal government jobs, which meant that, they had access to decent benefits. However, it doesn't mean that I wasn't exposed or didn't know that some folks really struggled with some of the basic things that we had. And then later, at an early age, pretty early age, maybe middle school, I realized that there were folks who had way more access to other benefits and lived more comfortably once I started attending a private school that was a predominantly white educational institution. And I remember conversations that my parents would have saying that they were making financial sacrifices to send me to this school, but knew that, getting a better education may mean that I could go to better colleges and get a better job and live more comfortably than, we did. And so I just think with all these things, just kind of a lot of questions growing up and thinking like, why are there these differences and what can be done to address the disparities that people experience? So in my position as a faculty member, I actually get to mentor students. And just today I spoke with a student and I was like, so why are you into health policy? And she kind of had the same response as me, saying, hey, I thought that one way to really change health outcomes and health behaviors was to become a medical provider or a clinician. And I kind of figured out what public health was and that there are ways to influence health behaviors and health outcomes. So the image that you see on this slide is the socio-ecological framework or model. And this model really showed me that there are lots of levels to address health outcomes and health behaviors. And for me, what was so enlightening was just understanding that policy is such a great lever to really shift the curve and to move not just individuals, but communities and just entire populations. I also had really great work experiences working in program evaluation with American Indian Alaska Native tribes and about injury prevention and how to evaluate their programs to inform tribal policy. I worked at the North Carolina Justice Center as an analyst and did a lot of community education and outreach. And even my work as a policy director on projects that worked on environmental health and even oral health. And what all of this has, kind of taught me is that no matter what part of the country you live in, what hobbies you like to do on the weekend, many people really want a freedom to be healthy. They want to know that they have access to healthcare and that they want their children to be healthy and their family members and their loved ones. And so how did I kind of come to, understanding health reform and actually start turning the curve into becoming a policy advocate? And I would really have to say it's interesting that we're speaking today and that this is the 10th anniversary or the 10th birthday for the Affordable Care Act. I remember sitting in classrooms in graduate school and professors just kind of saying, we're not going to go by the syllabus today because this is what's happening in healthcare. And this is actually like transformative moment. And having discussions about what would, ultimate or transformative healthcare reform look like. And at that time, when there was, little chats about there possibly being a public option in the Affordable Care Act and thinking, for the first time hearing this, this term single payer and how a public option could be a pathway to single payer. But as we all know, the Affordable Care Act did not end up having a public option. And then since, the enactment of the Affordable Care Act in 2010, it has experienced a lot of, litigation and has really been shaped by court decisions. One thing that has really maybe weakened the Affordable Care Act is that, Medicaid expansion was made optional. And that, again, while maybe more people have greater access to affordable healthcare, it still leaves way too many people underinsured and uninsured. So how did I kind of come even more to understand and supporting single payer? Despite the fact that the Affordable Care Act is the law of the land, I think we have seen lots of attacks on this law. Even though 53% of Americans say that they would view the Affordable Care Act favorably, that's not a strong majority. And there are still court cases. There are still attempts to weaken the Affordable Care Act and Medicaid. And so in some ways I say that this law has been left to wither on the vine, even though just think a few hours ago, I was on Twitter and saw that the US House Dems are introducing, I guess, quote unquote, an ACA 2. So, people are aspiring to strengthen and maybe the law. But despite, all the work to protect the Affordable Care Act and to promote Medicaid expansion, I feel that some of my work in communities, whether it be community forums or webinars, people still have questions about why isn't healthcare still affordable? Why do they pay so much for prescription drugs? And even this is happening in various states across the country. And I think there are, advocates who want to understand policy a bit more and how can we go a step further in my experience here in North Carolina. So this kind of gets me to why I feel that today and this moment, this year is really an opportunity for us as policy advocates to increase support for single payer. And, I don't think any of us are living under rocks right now and have heard about the United States is experiencing two pandemics. The first, I would say, is COVID-19. And the second is the United States is, kind of having a reckoning with its history with racism. So in regards to COVID-19, I do spend time on Twitter, and maybe I'm a little bit selective in who I follow on Twitter, but it seems that a conversation is shifting. People are, talking about essential workers, and these just aren't people in the healthcare industry. People are recognizing that, childcare providers, bus drivers, people that work in meat packaging places, grocery store workers and delivery services people are essential workers. And folks are kind of tying, making that link that essential workers oftentimes lack the benefits for paid sick leave and even access to affordable and quality health care, and still putting themselves at risk by going to work. And so I think people are seeing that there is a disconnect, and that maybe employee sponsored insurance isn't the best route. On top of that, I think the COVID-19 pandemic has really exposed the economic fragility in the United States. We're seeing lots of projections about employment levels and how many people are losing their jobs and turning to the marketplace or relying on Medicaid to try to get healthcare. We've also had Congress act quickly with the Families First Coronavirus Response Act and even the CARES Act. While, I think these were great steps, they aren't, for the long term. And a lot of these, and these acts also don't go far enough for the supports that people need. And I also think, with the action that Congress has taken, should hopefully be evidence to people that transformative health reform isn't just a pie in the sky aspiration. We can apply pressure to our political leaders and our lawmakers to make change quickly to address healthcare needs. And I think the COVID-19 pandemic is really exposing how great of need people have and how, access to care even before COVID-19 has impacted the health outcomes of folks currently. And that gets me to this slide, is that COVID-19 is also making people very much aware of health disparities. We are especially seeing disproportionate impacts on Latinx communities and the Black community. The Centers for Disease Control and Prevention have noted that a lot of reasons for racial and ethnic groups experiencing these disproportionate outcomes is because of the work environment and lack of benefits like paid sick leave, where they live and their access to amenities, and also health inequities like access to healthcare. And so that kind of links, nicely to racism in public health. We are noticing that states and lawmakers are recognizing that racism is a public health emergency. States are trying to figure out ways to address these systemic issues that leave some more people vulnerable to COVID-19. And I think nothing really kind of displays that link more so than, George Floyd, which may have sparked, the protests and the uprisings that we are seeing across the country, but the fact that he also tested positive for COVID. And on this slide, I have notes about the gardener's tale, and that's from Dr. Camara Jones. I really enjoy her work. And she talks about various levels of racism and how that impacts, people's perspectives. So there's institutionalized, there's personally mediated, but then also this gardener who's planting these seeds and the way he treats them, the seeds and the crops impacts how they view themselves and their behaviors. And so how all these levels of racism are connected and might, influence health outcomes. And so then, Dr. Camara Jones also talks about addressing social determinants of health, which many of us recognize, like where we live, we play, we worship, and where we learn. But she also says there are determinants of equity. And thinking about racism, thinking about our social norms in our country, like why do we feel that you have to work in order to have healthcare, or that, having access to, safe and drinkable water or food or secure housing is something that people have to prove that they deserve. And noticing, that these policies actually shape outcomes for folks. And so I think, many of us might have seen kind of an illustration that's on this slide showing equality versus equity. And that, if we notice that their policy is one determinant of equity, why not transformative healthcare reform? That could be one policy that can address racism and why, historically some racial and ethnic groups do not have access to healthcare. And it can also, help shift the curve and really help people feel like they are free, they have freedom from fearing that they will go into medical debt, freedom from fearing that they will, get COVID-19 and be stressed with their families. So I think that when we address social determinants of health, when we address determinants of equity through maybe some transformative health care policy, then we can really start thinking about social justice and true equity for everyone in this country. So I will actually wrap there. Thank you again so much for your time and for inviting me. And I, appreciate this moment, and I look forward to your questions. And I can pass it on to Hank.
Thank you very much, Sierra, and good evening, everyone. I'm a retired pulmonary and critical care physician, and I've spent the last dozen years working for healthcare reform because of the experiences that shaped me in my career, trying to give good care to my patients and the frustrations that I shared with my patients. In the next 15 minutes, I'm going to discuss options for healthcare reform that fulfill the League's position. So to approach a discussion of healthcare, we need to begin by affirming our values. Is healthcare a commodity? And by that, we mean a substance or product that's bought, sold, or traded. Those are activities that require a market. And in healthcare, there is a market for health insurance policies and for some selected items like medications and hearing aids. But for healthcare services, there's a crucial difference. There isn't a market. The market concept simply doesn't apply. And this was explained by the Nobel Prize-winning economist Kenneth Arrow in a 1963 paper entitled Uncertainty and the Welfare Economics of Medical Care.
Excuse me a minute, Hank. Hank, can we see your slides? Are you going to share those with us?
I thought that they were shared. I'm terribly sorry. Do you see them now?
All right, we do. Thank you so much.
Okay. So to continue, healthcare is not a commodity. There is no market for healthcare services. And for those who still insist there's a market, I would say that despite much effort at health market reform, healthcare is a lesson in market failure. So the predominant view is that healthcare is a necessity for everyone. And many people would regard it as a public good, which means it's a service that's provided without profit, so all can benefit. And examples would be public education or a fire department. And now I can't change my slide for some reason. So forgive me, let me go back. Ah, there we go. Okay. Access, cost, and quality are called the three pillars of healthcare, of a healthcare system. And despite the good intentions of the Affordable Care Act, access is still not adequate for the uninsured, but an even larger number of underinsured have difficulty with timely access because it's beyond reach due to the very high deductibles that are often beyond people's means. And the remedy here would be to redesign a healthcare system based on inclusion and equity that was so nicely described by Sierra. The second of the pillars of a healthcare system is cost. And the current healthcare system, I think, is universally regarded as costly at an unsustainable level. It's an enormous burden, not only for individuals and families, but for employers and for society as a whole. And the costs continue to rise to levels that are not sustainable. Many of you will recall Warren Buffett's comment that medical costs are the tapeworm of American economic competitiveness. And from a business perspective, the way healthcare is organized violates principles of fiscal responsibility because it lacks prudent and sustainable use of precious economic resources, economic efficiency, avoidance of waste, fiscal transparency, and accountability. So the remedy, of course, is fiscal responsibility and fair progressive financing, and other details that would lead to a sustainable cost for healthcare. And I'm going to go into that a little bit in a moment. But let's talk about quality. Despite our technology and our highly skilled workforce, the US falls way short of other countries in life expectancy and in many other outcome measures. Sierra touched on the lessons of COVID-19, and I would just like to reiterate that it brought into glaring prominence the lack that many people have to timely access to testing and treatment. There was inept leadership in many aspects of how the healthcare system responded to the pandemic, and how the public health system fell short of keeping things in balance with the healthcare delivery system. We saw and became much more attentive to the vulnerability of our workforce and delivery system. We're experiencing the impact of systemic racism, and it's coming out in so many ways, but clearly in the context of the pandemic. And finally, we see the futility, really, of linking healthcare to employment. It's self-defeating, especially at a time when so many people are being thrown into unemployment and then losing their healthcare as a result. There have been many attempts in the past dozen years or so to try to address some of the deficiencies in our healthcare system through incremental change. And incremental changes force trade-offs between access, cost, and quality that are simply not necessary. So as we go down this slide, you can see that some of the changes that have been given the most attention, such as the Affordable Care Act, Medicaid expansion, public option, letting the free market do its whatever it's supposed to do, or imposing regulations on our private insurance companies, all fall short in fulfilling things that are fundamental to the values that we hold and to the position of the League of Women Voters. None of them, and I want to emphasize this, none of them would bring everybody into contact with the healthcare system. There would still be people who would be excluded from having access to healthcare because they lack insurance or they are in a plan that's unaffordable. Even within the Affordable Care Act, we see that. None of them would offer comprehensive benefits. Think of the things that are not included in even the Cadillac health insurance policies. How many policies include not only care for acute and chronic illness, but include long-term care, include mental health services on a parity with physical needs, and so forth. So none of these would allow for a choice of provider on the part of the patient. None of them would offer portability so that the individual retains access to healthcare through their participation in the healthcare system, regardless of whether they move from job to job or state to state. And none of them would achieve the affordability that's necessary because they simply leave enormous amounts of economic waste in the system. So none of these incremental changes meets the League of Women Voters position. let's look at single payer, sometimes called improved Medicare for all. And I want to emphasize that we're not simply talking about the traditional Medicare extended to everybody. We're talking about an improved Medicare for all, which is different in certain key features. First of all, in access, it would cover everybody. So there would be equitability, no financial barriers, and reduction of disparities. The cost would be sustainable. There would be no profit in the delivery of healthcare services. There would be profit, for example, in pharmaceuticals, but that lies outside the interaction between the patient and the healthcare provider. So the healthcare delivery system would not be profit driven. There would be no private hospitals. There would be no private equity companies buying up health ambulances and hospice programs and other programs that provide direct services. It would be efficient and fiscally responsible. And as far as quality, it would be comprehensive. And what you see here are a listing of the things that are often left out of existing health insurance, such as behavioral health, as I mentioned, on a parity with physical health needs, reproductive health in all of its facets, all prescription drugs would be covered, dental care, hearing and vision aids, rehab, long-term care, and more details that I haven't even included. But what you can see is that virtually all of the healthcare needs that we experience in our lifetime, for which we look to the healthcare delivery system to provide, would be included in a single payer improved Medicare for all program. The other thing about quality is that by taking, by modulating and downplaying the money-driven economic imperatives that are having an inordinate influence on, for example, how long you can be face-to-face with your provider, how long your provider can schedule an appointment time with you. These things would be eliminated, and providers would simply be adhering to best practices. So the decision about diagnosis and treatment would be between you and your provider, and not by an insurance company that's looking at the money side of things. And then there'd be other attributes to an improved Medicare for all program. It would eliminate completely the need for Medigap and Medicare Advantage plans. There'd be simplicity, which would make things a lot easier for the providers, both physicians and clinics and hospitals that have enormous commitments to simply dealing with paperwork under the current system. There'd be security and peace of mind because people would have access to healthcare from the time they're born till the time they die without having to read the fine print and see if something is going to be excluded. And it's been proven to work in many countries, and we know from evidence that it would work equally well in the United States. So this is evidence-based policy. So here's where things stand. The league position is simply unfulfilled. The league created a position in 1993. You've heard what it is, and we're not there yet. We don't have a universal system. We don't have an affordable system, and we don't have a system that meets our expectations in terms of quality. But the league position is attainable through legislation. And I encourage everybody to actually look at the Medicare for All Act of 2019. This is the most recent successor to a long sequence of model legislation that could actually bring about the creation of a high quality affordable, and universally accessible healthcare system. So this is House of Representatives Bill 1384, sponsored by Representative Pramila Jayapal from Seattle, and it has 116 co-sponsors. And if it were to pass in the House and Senate, and then signed by the president, it would then begin a process of conversion in a matter of just a couple of years to a completely transformed healthcare system that would meet the League's aspirations. Now, this will also entail some things that lie beyond legislation, such as effective program administration, planning and allocation of resources, delivery system reform, professional education, workplace development, improvements in public health, and addressing the social determinants of health. So we mustn't think that simply changing the payment system or the financing system is a panacea that's going to immediately give us the perfect healthcare delivery system. Perfection will never be attainable. There's a process of continuous quality improvement and adjustment, and healthcare has to keep up with the new discoveries brought to us by not only hard science, natural science, but also social science. So this is a continued quest, but none of these other changes can be fulfilled unless we change the program through which we deliver healthcare. So in the last couple of slides, I want to just touch on the question of the economics. And the way that economists can tell us how a single payer system or any other modification would compare with what we're paying now is to start with an estimate of the healthcare cost under the current system. And this is available on a national level. It's also available on state levels. And these statistics are updated every year by the federal government. So we know what the total national healthcare expenditure is. And if we want a single payer system that's comprehensive and covers everybody, we're going to have to add new costs to do that, to cover the long-term care, to cover the mental health or behavioral health improvements, to cover all the prescription drugs and so forth. So we can calculate quite well what those new added costs are going to be. But then we start to look at the enormous amount of administrative waste, something like $500 to $600 billion per year at the present time. We look at the excessive pharmaceutical prices, why in the US, the VA system is able to purchase pharmaceuticals for half the cost that the rest of us pay, why Medicare is not allowed to negotiate drug prices, why people in the US pay more than people in Canada and other developed countries. So these excess prices, not only for pharmaceuticals, but for other elements that have a decisive impact, will be eliminated because there'll be a negotiation between the National Healthcare Administration and these providers. And this negotiation will result in fair prices that will allow them to continue making a profit, doing research and producing good products and good services. But this is the way it works in other countries, and it can work this way in the US as well. And there'll be other service reforms. So taking the estimate A, so adding the new cost B, and then subtracting the savings C, brings us to the cost under the proposed single payer program. It's very simple bookkeeping. And in fact, I might add that this is not socialized medicine. It is, I like to tell my friends, it is socialized bookkeeping. And that's really what we're talking about here. So this is my last slide. And I would propose that single payer is really the only path ahead to get to the aspirations that the League put into its healthcare position in 1993. Now, when you go through these cost projections, it's been done in studies of high quality 22 times in the past 30 years. And every one of these studies has supported the potential for long-term cost savings. A reasonable estimate would be that the net cost of a single-payer improved Medicare for All system would be 10% below current costs. It may actually be higher, but this is a conservative estimate. And everybody will be covered and the benefits will be comprehensive. So how do we pay for it? Well, 60 to 70% of the total cost is already being paid for through current public funding. We don't have to change anything. We just continue the public funding that we have now. And this varies by state. Some states have slightly higher. In California, it's close to 70% of the healthcare expenditure of our state being funded through public funding streams. So all we have to do is replace the remainder, which is now being paid by premiums and out-of-pocket expenses. A lot of the premiums are paid by employers, but then they're taken away from the compensation of workers. So in the end, workers are paying those premiums, employees are paying them, and then we're all reaching into our pockets every time we need healthcare and paying out-of-pocket deductibles and co-payments. So we need to replace that with taxes. The beauty of the system is those taxes will be less than what people are paying now. And almost the entire population will save to a degree greater than $1,000. We're currently paying $11,172 per capita per year for healthcare. And $1,000 for every child, woman, and man in the country could be committed to other necessary expenditures like education, like housing, and so forth. The distribution of savings among people of lower, middle, and high income will depend on the tax structure. But again, almost the entire population will save. The taxes have to be progressive, they have to be stable. But I would just conclude by saying the obstacle to having a well-designed, evidence-based, policy-driven, humanly responsive healthcare system is simply that we haven't achieved the political will to do it. So I want to close with this quote: when the proposed policy is right and the politics are wrong, you don't change the policy, you change the politics.
Thank you, Hank. Thank you very much. We have some questions that have come in, and I'd like to start with one that came to Sierra. She was asked to talk a little bit about what does the freedom to be healthy? What is that really?
Yeah, and so I responded in the chat, so I will just read what I chatted. And I think just to give people some background, I read an article recently in The Atlantic by the author Ibram Kendi, who wrote the book How to Be an Anti-Racist. And he had an article about what does the Trump administration mean about freedom? And he had this great analogy of what does freedom to mean versus freedom from mean. And a lot of times freedom from is for vulnerable populations, people who have not experienced power, who may have been oppressed. And freedom to is folks who feel like they have agency and maybe privilege. And so when, asking to explain what did I mean by freedom to be healthy, as a public health, with a public health background, a lot of times I always look to WHO or the CDC, and WHO says that health is the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And to, so really to be healthy, or freedom to be actively healthy, is kind of hard in the United States, as we have policies and beliefs that make it hard for people to even just get to the absence of disease or infirmity. So if we're really working towards equity and justice, we can hopefully get rid of these disparities between groups. My experience, being a policy advocate and going into communities throughout North Carolina shows that, when you're speaking to folks who are uninsured or underinsured, they really feel trapped. They don't feel like they have any kind of agency to be able to like access care, or not have that worry that they're going into medical debt. And so I think, if we're going to have health policies that are going to help us get towards equity and justice, I think it will make, decrease the burden that people have, to achieve health, and feel that they are healthy. And, what would be the outcome of more people being free to be healthy would be that it shouldn't depend on your zip code, or the color of your skin, or the language that your parents speak in the home, that, could already determine your life expectancy and, maybe what, health outcomes that you have. We really want everyone to be able to really reach their full potential and have the definition of health that they see.
All right. Thank you. Here's a question that came up a couple of times, and that is, if we move to a single payer system, what happens to all the people who are involved and employed by insurance and other companies that would no longer have jobs? That one, Hank may want to.
So that's a very important question. And what we refer to in healthcare legislation that addresses that is the just transition. Just transition, I think, is an expression that has been used in other situations. But in all of the single payer legislation, and I didn't mention Bernie Sanders' bill in the Senate, it's a little bit different. The bill that I think is the most advanced is the one I referred to, HR 1384. There's funding for both unemployment benefits and job retraining for all of the people who are displaced from work that would become unnecessary. The enormous clerical staff that is now committed to dealing with the paperwork, those people can be repurposed to do other things. Many of them have other skills. We need them to be helping to provide healthcare, and some of them will enter the healthcare workforce. Other people will enter other jobs, but that's taken care of. And even though that amount of transition seems to be quite appreciable, it's only about the equivalent of 1 month's worth of the job changes that take place day in and day out in this country due to people voluntarily changing jobs, being laid off, and so forth. So it's well within the scale of what we deal with in our normal lives. But the just transition will be accounted for, and nobody will lose economically as a result.
Okay, thanks, Hank. I think that rather than go on with a few more questions now, we'll switch and go right to our call to action, because we're coming up towards the last quarter of our program tonight. And I'd like to call on Betty Keller to talk about that. And we will have time for questions after her presentation also. Betty?
Good evening. I'm pulling up my share screen here, and let's see here. Can you all see this now? Great, thank you. So I'm Betty Keller. I'm a member of the League of Women Voters of Vermont. I don't have a local league because I'm too rural in my my corner of the state. So I'm just a member at large. I'm also the president of the Vermont chapter of the Physicians for National Health program. recent enough that that's not even on our webpage updated yet. And I am the chair of the Education and Advocacy Committee for One Payer States. And I am so glad that you all are still with us here at this time of the evening after some of you have been on many hours of Zoom. So I thank you for hanging in there here with us. What I'd like to speak with you about is what you can do to try to help us achieve this crucial goal of getting healthcare for everyone in our country. First, if you do not feel comfortable currently in trying to persuade anyone else to support single payer, then some opportunities for educating yourself are to look at the toolkit on the League of Women Voters website. We have the link here. It's been in emails we've sent around. It'll be in emails following up afterward. And if you just signed up for this caucus using a YouTube link and not having registered with the Zoom, then you can get on our mailing list to get this information at lwv.healthcare.questions@gmail.com. And so then we can give you the link. You can also look at other trusted websites like pnhp.org. They have this great segment called the Kitchen Table Talks. OnePayerStates.org, which has been doing these OPS office hours I'll be talking with you about, and HealthcareNow.org, all great sites for educating yourself. The OPS office hours have been going on a couple times a month for the last couple of months, and the League of Women Voters will be doing, this group that organized this caucus will be doing a tutorial on July 7th. In addition, a group of us have been in, Linda had mentioned at the very beginning, the Healthcare Reform Network of the League of Women Voters. There's both a monthly phone call and an email Google group that we communicate with. So these are all great resources for staying connected and keeping up to date on what things are happening and how you can educate yourself and advocate. So the OPS office hours, the next one will be on June 30th from 5 to 8 p.m. Pacific time. And this was specifically chosen as a time to be soon enough that when you all are still motivated from this caucus, that you can follow up on it. And there will be a beginning to learn the basics of single payer at 5:30. And other than the main room having that talk, the rest will be focus groups that will meet in the breakout rooms with volunteers. So from 5 to 6:30, that will be for people who already understand single payer and want to sneak out and go into a breakout room. And after the basic presentation, there'll be time for more questions and answers and more breakout room trainings. The League of Women Voters tutorials, I'm having trouble getting my arrows to work. The League of Women Voters tutorials will be specific for activities that league members are interested in. How do you educate your local league and state league? How do you develop an effective healthcare committee in your league? Developing relationships with your elected officials, finding advocates in your state and collaborating with them, and using social media to amplify your message. So that tutorial will be on Tuesday night, July 7th, 4 to 6 p.m. Pacific time. Additional topics will be selected from those that you all request, either in the chat bar or by sending an email or by responding to the email and survey that we'll be sending out after this caucus. So after you've gotten the education that you need to feel more comfortable, then you want to advocate for what is best for our country. This is a nonpartisan issue. It's only partisan by people who oppose it. In other countries that have healthcare systems that cover everyone, officials will not get elected if they do not support their healthcare system. You need to talk to people with different perspectives. If you only talk to people who already agree with you, we won't build support. Better together, find allies to work with you, and find a network of support if you're feeling lonely. If you're living in a community where there are not a lot of other people who are actively working for it now, things like the healthcare network can be a good place to make connections. Community networks. In this day when door-to-door campaigns and rallies are not appropriate, you need to think outside the box. You can ask a faith community, a book group, parent-teacher organization, civic organization, or other community group to host a discussion. You can invite elected officials, hospital administrators, or others to listening sessions. Some places call them town meetings, town halls. You can also create earned media opportunities and send photos and press releases to your local media. And if you don't know what earned media is, that would be a good reason to go to the tutorials. Regarding social media, some of you are already on Facebook and other platforms. If you aren't currently, I'd suggest you just choose one so you can figure out how to use that one most effectively. So you want to identify sources whose voices you want to amplify, figure out which platform best fits your interests, your temperament, the time you have. Learn how to use it effectively. If you have not used Twitter and you're interested, one of our members, Ruth Herenchar, is willing to work with folks, so you can mention that in the chat bar or in an email response. Instagram, Reddit, and Facebook are other platforms you may want to consider. So our goals are to motivate the League of Women Voters of the United States to actively advocate for the League's position, to really build grassroots momentum so that we will go forward on supporting the position that we chose a long time ago. Also to educate elected officials, state administrations, and hospital administrators and boards on the urgent need and the viability of a publicly funded healthcare system. We need to recruit advocates from varied perspectives, enhancing the message that this is nonpartisan and that support is broad-based. And we need to educate the public until it is politically impossible for elected officials to oppose single payer. That's how we got the bill passed in Vermont. We've had challenges with that after the fact, but it got to where politicians had to support it because they would not get elected if they opposed it. So right here, thank you so much for your time and your attention. And thank you so much to Sierra and Hank for your presentations. And I look forward to having you folks provide more answers to questions after this. We need healthy people for healthy democracy. We need good health so we're able to go to legislatures, to write letters, to get out and vote, to run for office, to study the issues. You can't participate fully if you are sick, if you are tied up trying to fight with your insurance companies for coverage, or working 2 jobs to pay for your insurance premiums and your out-of-pocket expenses. With the urgency of this pandemic upon us, with the glaring light that it is focused on racial injustice throughout our culture, with devastating effects on the health and lives of people of color, please ponder how you can use your skills and your experience to help us achieve healthcare for all of our families and our communities now. These trainings on June 30th and July 7th are interactive and do not have nearly the capacity that this caucus has. I didn't see how many people we had on this, because I can't see what YouTube has, but I expect we had several hundred people at this caucus. We only have capacity for 100 people at a training with the work it takes to manage the custom breakout rooms. So if you can help with these trainings, please let us know at that email address that I gave so we can plan more trainings with your help. We need to mobilize everyone who cares about healthcare, and that means you. Thank you. So Linda, I'd like you to take over getting to some more questions if people had more. And those of you who needed to leave by 9 o'clock, I think we're probably close to there.
Yes, thanks, Betty. So all 3 of our speakers actually have agreed to stay on a little bit if you would like to take some more questions. But if you wouldn't, we understand it's late on the East Coast. Please watch for an email from us that will have a link for this recording, a link for a survey where you can ask some more questions. Sierra has graciously agreed to respond to those if some are directed right to her. And we hope to keep you in our network and have you join our Google group or our conference calls, and opportunities to do that will be sent in the follow-up survey. And a reminder to those of you who joined directly from the YouTube link, if you would go to that Gmail address and send us your email, we'd like to have that. And again, it's lwv.healthcare.questions@gmail.com. So I do have a couple of more questions. One for maybe Hank. This asks, are individuals under the Medicare for All who are currently incarcerated or in detention centers covered?
Yes.
Okay.
Every resident of the United States is covered.
All right. Here's another one. What's your opinion about states attempting to create their own state single-payer financing system, or perhaps joining in a region, 3 or 4 states, to create a regional system? What are some of the pros and cons of this kind of smaller system? Betty, do you want to take an answer at that?
Sure. So I think that right now it's a little bit risky because we don't have the bill HR 5010, which would enable states to work more closely with what's the word? So the federal government has some barriers for us to have an effective single payer system that can really get those administrative savings. And HR 5010 helps with the workarounds for that. We also need to pass a bill that would allow states to not have to comply with ERISA. So those two things would need to happen to have it really be the most cost effective that it could be. For a small state like Vermont, when you crunch the numbers, it could be borderline whether you could save enough to actually do it. And you definitely can't without getting those two things accomplished. For a large state like California, you're bigger than a lot of countries. So surely you could actually do this. And the regional question is, there are some barriers to interstate commerce, but you can also do interstate compacts. So it might be something like you negotiated to have a larger pool in the negotiations for pharmaceutical prices. And you would do some collaboration about having your coverage covered. You know, if people lived on one side of a border and worked on the other, you'd work those things out together. But regional, it probably has a few more barriers than state, but if you're a small state and state-based alone is not going to cut it, then regional would be an option. But places like New York and California could do state-based.
All right, thank you. Here's another one. She asks, it seems to me that all of us, all individuals and organizations that want Medicare for all, need to be united and coordinate our efforts. What can the League do to help bring this about? And what are the chances that senators and representatives who favor Medicare for all can help in this? Hank, would you like to answer that one? I think I've heard you talking about this.
I think it requires building a large coalition that's effective, but we think of other social issues where probably most people can identify a organization that on a national level that's advocating for their position, an organization that is both connected with the grassroots and also connected with legislators in DC and in the various state capitals. We don't really have that yet in the Medicare for All movement. There might be some exceptions, but in general, we don't. We don't have an effective large coalition in California. So I happen to believe that this is something that would be best done at the national level. I hear what Betty said, but even if it were to be done at a state level, it requires federal cooperation so that barriers to states having custody of money that's now in the Medicare and Medicaid budgets would come under state jurisdiction. So we need to form coalitions. It can start at the state level, but ultimately all those coalitions need to connect. And we need to make an impact on the people whom we hire to pass the legislation that will allow us to do this.
Betty or Sierra, would you like to add?
Actually, we don't have a lot of time probably before people are leaving. I did want to make sure we answered one of the questions that somebody had sent regarding HR 6909 and S 3790.
Thank you. Go ahead.
Right. So I'll read the question. Could you please comment on HR 6909 and S 3790, the Emergency Healthcare Guarantee Act? I'm feeling so hopeful that attendees see the opportunity in the passage of these bills to make a big leap forward reaching so many supporters and demonstrating the enthusiasm of the League's healthcare reform network for achieving a universal single-payer system of healthcare financing is truly a happening. What should we do as individuals and as leagues? What should we ask the League of Women Voters of the United States to do? So for those of you who aren't familiar, the Emergency Healthcare Guarantee Act is a great bill. They have, I don't know the current number of supporters, but they definitely need more. You want as many as you can get while they're going through these committees. So this bill provides for people who have become uninsured through the pandemic, and also those who were already uninsured, to go on Medicare now, or at least have Medicare paid their bills now, and to have the co-pays, deductibles, all the out-of-pocket costs for everyone, even if they're on private insurance, to be paid by Medicare. And through the time until there's an effective vaccine for COVID-19. And that is a huge, huge improvement for our country, for all those people who have lost their jobs because of this pandemic, and for people who were uninsured before that anyway. And for those who are underinsured, everyone who is underinsured would no longer have that barrier to care. That if they had a cough and they were nervous, they could go and have somebody take a look at them and decide whether they need testing, all that sort of thing. So that is a great bill. The companion bill in the Senate also could use some co-sponsors, but the one in the House is the one that's getting more attention as they try to get that, accepted into a committee. And all the things that we talked about for how you could advocate for 1384 are things you can do as far as reaching out to your elected officials, writing letters to the editor in support of it, all those sorts of things, just educating people about the benefits of this. And the more people we can get to do that fast, the better, because this is just an emergency bill for right now. It'll go away after we have the vaccine. There shouldn't be as much opposition to it to take care of people now. Thank you.
All right, thank you. Are there other questions that you have seen in the chat? I think I've gone through most of those that were relevant for this part of our program. So perhaps I'll just conclude by saying that we hope many of you will join our network to continue this conversation, to continue tossing these questions around, and keep working at your local levels to find your allies so that you can put things together and build your critical mass. Thank you all very much for joining us tonight, and we'll look forward to seeing you again, hopefully at our League tutorial.
Thank you. Very well.
Thank you.
Very dense.